Hello everyone. Today we will be discussing about the anti-tubercular drug, that is for the B.Pharm medicinal chemistry, 6th semester. We know tuberculosis are a very deadly disease which causes infection through the Mycobacterium tuberculosis, which causes persistent cough, fever, weight loss, and then day by day immunity problem, and lastly to death. And along with the tuberculosis, different infection also comes. So the disease is caused through the bacteria known as the mycobacteria. They are slow growing bacillus and they are dormant forms in macrophages. They are very slow and they can hide in different organ also, and they are available as a macrophages. They can kill 2 million people each year, increase incidence due to HIV associated mycobacteria, and their prevalence in TB in Sri Lanka is 79 per 1000 population. Like this TB can be found in tropical area, subtropical area, in the humid area, and in the malnutrition property, low income property, low income countries, and immunity deprived person also. The drugs were developed 40 years ago, but now different new multi-drug resistant strains are emerging. That means some bacteria, of the bacteria of the tuberculosis, is not dying with the normal drugs. That's why anti-tubercular drug has been classified into two categories: first-line drug and second-line drug. So first-line drug is known as the drugs which will be primarily giving effects in the tuberculosis when they are diagnosed firstly. So the drugs are isoniazid, rifampicin, ethambutol, pyrazinamide, and the second line or second category of the drug is shown as clarithromycin, ciprofloxacin, capreomycin, cyclosporin, kanamycin, amikacin, and streptomycin. This drug can causes different benefits to the disease, where it can help the persons when second category of infection is again prevented. Now, this is the isoniazid, which is known as the isonicotinic acid hydrazide, which is a which is a six-membered, one nitrogen-containing heterocyclic moiety with a hydrazide moiety that acts on the mycobacteria that interferes with the mycolic acid synthesis unique to Mycobacter cell wall. Actually, TB bacteria is very tough to kill because the cell wall contains different type of component like mycolic acid, peptidoglycan coding channel, which is tough to kill, like the general gram-positive and gram-negative bacteria. So the drug freely passes through the mammalian cell wall and effective for intercellular organism also. They can pass through the placenta to fetus. That's why if any mother is affected through the TB, their fetus can be affected. They are bacteriostatic to resting organism. They are bactericidal to multiplying organism. Now going to the synthesis. Firstly, the picoline, that is 1-methyl pyridine, we can say, is oxidized in presence of KMnO4, and they are formed isonicotinic acid. Again, in the presence of ethanol and sulfuric acid, they are ethyl isonicotinate, and with the hydrogen moiety NH2NH2, the isoniazid is formed. Next, we are going to the isoniazid pharmacokinetic. They are well absorbed from GIT. Fatty food and aluminum containing antacid may reduce their absorption. CSF, that means cerebrospinal fluid penetration, is 20% of the plasma concentration with non-inflamed meningitis. In case of meningitis, if there is inflammation, the drug can penetrate very easily. Penetrate well into causes material, cyst material, and excretion through the urine. They can produce some toxicity to the liver also. They are metabolized by acetylation process. If slow acetylation is gone, then better response can be given with the T-half of 3 hours. But fast acetylation, the drug will be active for 1 hour. Now about hepatotoxicity, polyneuropathy, these are the different adverse effects: rashes, acne, and hemolytic anemia can be found in case of person who is having GCPD deficiency. Like glucose 6-phosphate dehydrogenase, one of the enzymes that helps in the glycolysis process, will be affected. This is the skin rashes in case of isoniazid treatment. Now coming to the second drug, that is a rifampicin. This is a good drug which can inhibit the bacterial DNA-dependent RNA polymerase, which will be affecting in the bacterial RNA polymerase. As a result, the DNA or RNA cannot be multiplying. This is bactericidal in nature. They are effectively gram-positive and gram-negative bacteria can be killed. This is a structure where it is known as the 3-methyl. You can see 3-methyl, 4 1 piperazine. This moiety is known as piperazine and rifampicin. Resistant chemically modification of DNA-dependent RNA polymerase. If the DNA-dependent RNA polymerase enzyme is modified, then this drug cannot act. Then the drug will be resisted. They are also well absorbed from GIT, and that they can penetrate the CSF in 10 to 40%. And elimination is done through the hepatic cells and renal cells. So they also produces rashes, hepatotoxicity, and thrombocytopenia. Liver enzyme can be elevated in case of this drug treatment. Orange discoloration of urine can be found with sweat and tears, and the cytochrome 450 enzyme can reduce the serum level of the drugs, and some warfarin and estrogen drug also reduce the effects of this drug. Now coming to the third category, that is the ethambutol. That is one of the important drug. So that inhibits the arabinosyl transferase enzyme that is involved in the cell wall biosynthesis. In case of bacteria, the enzyme is deactivated. As a result, the cell wall will be destroyed. It is bacteriostatic to tuberculosis. That means the growth of the bacteria will be inhibited. Resistance developed rapidly if used alone, because this drug cannot be given singly. As a result, it will be resistant. And another drugs like rifampicin, ethambutol, isoniazid should be given with the ethambutol. This is the structure, ethambutol. Butanol, we can say CH2CH3N, and along with ammonia is there. And ethanol group is there, C2H5, CH2H, CH2H, and C2H5. Okay, they are commonly known as 2,2-ethylene diamine, di-2-methyl guanol. They are well absorbed from GIT. Viability is 80%. Their CSF penetration is very poor, and elimination through renal. Their adverse effects like they are having red-green color blindness, reduced visual activity, growth-related problem can be there, maybe reverse, maybe unilateral and reversible. If the drug is withdrawn, then the infection will not be given or the toxicity will not be seen so much. Now pyrazinamide, another category drug. Pyrazine 2-carboxamide. This is 2-nitrogen containing heterocyclic moiety, that is known as pyrazine. And at 2-position carboxamide, CONH2 is there. That interferes with the mycobacterial fatty acid synthesis also for the cell wall. They inactivate the mycobacterial acidic pH. The drug will be lowered. Okay, and effective intercellular organism in macrophages. They are also well absorbed from the GIT, and CSF penetration equal to plasma concentration. They can easily penetrate the CSF. Hepatic metabolism also found, and excretion is through kidney. Their adverse effect is GI disturbance, hepatotoxicity, and hyperuricemia. Gout can be there, and arthralgia, pain in the joints. These are the second line drug like erythromycin, ciprofloxacin, and capromycin, cyclosporin, kanamycin, amikacin, streptomycin. You can see the structure. Streptomycin, which is already found, they contain 3 glucose sugar along with some amino moiety. They are bactericidal in nature. They are poorly absorbed from GIT. Given IM, their CSF penetration is poor. They are eliminated through the kidney or renal excretion power. Ototoxicity, vestibular toxicity, and nephrotoxicity is a toxic problem. Hearing problem can be there, or the vestibular toxicity in case of male, or nephron can be damaged. They are used in very ill patients. Multi-drug resistance can be for the patient which is having multi-drug resistance. And if any person is not showing response to the treatment, they can be given this drug. Okay. Now capromycin, these are the effect 8-quinolone, deafness, ataxia. They are broad spectrum antibiotic. They reaches the CSF well, causes CNS side effect, and used in drug resistant TB. Some case of drug resistant, in case of normal drug cannot treat, they have to give in cyclosporin. In case of pulmonary TB, for the second month, we should give the isoniazid pyridoxine, rifampicin, ethambutol, pyrazinamide. For the continuous 4th month, we should give the INH, pyridoxine, and rifampicin. Anti-TB therapy. Multiple drugs are used to reduce the emergence of resistance, given as a combination tablet. taken 30 minutes before the breakfast as absorption of nutrition is influenced by food. That means rifampicin should be taken 30 minutes before the breakfast because food can reduce the absorption. These are the four category of drug: ethambutol, rifampicin, isoniazid, and cycloserine. A fixed dose combination, that is FDC, for two or more active ingredients combined in a single dose, they improve medication compliance because any patient cannot take four drugs continuously. So they have given the one single dose which is combined with all four drugs. To target a single disease like AIDS, TB, and malaria, this is also formed. Pulmonary TB 6-month treatment should be given. For renal, bone, and CNS treatment, longer treatment is required. Sometimes drug resistance is found in case of multiple resistance and extensive drug resistance. Sometimes the amikacin, scaprimycin, and kanamycin will be given in case the TB bacteria is not treated. Now, drug resistance continue. Primary drug resistance, the exposed to resistance organisms. Secondary resistance again continue after initial drug sensitivity and due to non-compliance. Sometimes these drugs shows a resistance to the another drugs. That's why given the second line drugs. Their treatment is for 2 years, and if HIV positive patient found, they have to be treated, as well as after 12 months they have to show negative culture. If negative culture is shown for the bacillus, then it should be confirmed that the patient is cured for TB. There are DOTS therapy, which is very closely known from the government service, that is a directly observed therapy to improve the compliance, where hospital stay or the patient who are uncooperative, who are residing in slum area, who can skip the disease, who can skip the medication, they are come into contact with the OPD or in the direct observation therapy, they are taken into the health center. So use a combination of drug for a long period. If resistance is emerging, then first line drug, second line drug should be given. This is a Mycobacterium tuberculosis bacteria. Isoniazid will inhibit the cell wall. Ethambutol inhibit the aminoglycolactam. Pyrazinamide, they will inhibit the plasma membrane, and they will also prevent the synthesis of ATP in the cell wall. And another drug like rifampicin, and they can inhibit the DNA polymerase synthesis. By this way, we can summary continues. As soon as a bactericidal to rapidly dividing bacteria. Then rifampicin, they kill intercellular bacteria. Then ethambutol, bacteriostatic against multiplying bacteria. Pyrazinamide kill dormant bacteria. So thank you everyone. I'm completing here.